Thank you very much to the Society for the invitation to speak today. I'll keep this pretty brief. I have no disclosures relevant to today's talk. Main objectives are to review the diagnosis and treatment of both H. pylori, and then I'll define intestinal overgrowth, and then go over diagnosis and treatment of the subtypes of both SIBO and intestinal methanogen overgrowth. So to start with H. pylori, it is a microaerophilic gram-negative bacteria that's usually found in the stomach or even proximal duodenum, and it gets there through fecal-oral transmission most commonly. And the H. pylori will release urease or other toxins that then increase acid secretion in the stomach, and that leads to the pathogenesis of it. It's implicated in up to 90% of cases of peptic ulcer disease, as well as gastritis, gastric cancer, both adenocarcinoma and malt lymphomas. So diagnostic testing for it, there's both non-invasive and invasive testing for it. And the ones that I've highlighted in pink, those are the ones that are really checking for active infections. And so those are the ones to really focus on, both the urea breath test and stool antigen test. Serum antibody can be done, but you can't tell if it's active or previously treated infection since it's checking for antibodies. So this is really only used for screening in high-risk areas and for patients that haven't ever received treatment before. And then endoscopic biopsy. So urea breath test, this takes advantage of the urease that's released by the H. pylori bacteria, and it measures the amount of CO2 that's in the breath after ingestion of carbon-tagged urea. And the urease will then convert it to ammonia and CO2. CO2 levels will rise in the breath. And that's what's picked up on. It has over 90% sensitivity and specificity, but you do have to hold PPIs, H2 blockers, and any bismuth for 2 weeks to improve that sensitivity. The stool antigen test is an immunoassay that would detect the H. pylori antigen in the feces, and this is a very cost-effective diagnostic tool that also has high sensitivity and specificity. Same limitations, though, that you do need to stop the PPIs, H2s, and bismuths for about 2 weeks to improve that sensitivity. And then endoscopically, mucosal biopsy, the H. pylori can be found anywhere from usually antrum up to as high as kind of mid-gastric body. So it is recommended to get biopsies from both antrum and mid-body. I'll usually get 2 from each site. Histologically, if it's just for histologic evaluation, it can get sent in formalin, but in refractory cases, if you're checking for cultures or antibiotic sensitivities, best to send it down in saline, or if there's any questions, just check with your pathologist or microbiologist beforehand. And then the rapid urease test is a kit that can be used, again, that takes advantage of that urease. It's a medium with urea in it as well as a pH indicator. And if H. pylori is present within the tissue, it'll release the ammonia, and that will increase the pH, and the detector will change color accordingly. And then for treatment, standard triple or quadruple therapy. For the sake of time, you can take a picture of that. But it is recommended to check for eradication 4 weeks after treatment, and we usually do this, again, with one of the non-invasive measures of either the urea breath test and stool antigen test. One thing I didn't mention is who to test for this. Generally, patients with dyspepsia, peptic ulcer disease. If you've done an endoscopy and you're finding any type of mass ulceration, new malignancies, or preoperatively if you're planning for some type of bariatric surgery or an anastomotic procedure in the foregut, it is a good idea to check for H. pylori. So intestinal overgrowth, the one most commonly heard about is small intestinal bacterial overgrowth, or SIBO, but there is a second subtype of it, intestinal methanogen overgrowth, IMO. So with SIBO, it's excessive amounts of usually gram-negative bacteria that are found in the small intestine, which then leads to pathologic fermentation of carbs to then produce gas, which causes IBS-like symptoms, particularly bloating. The guidelines on it are a little bit mixed, but the generally accepted consensus is bacterial population over 1,000 colony-forming units per ml. For IMO, it's more of a methanogen overgrowth that occurs in both the small bowel and the colon, and this comes from the archaea domain. It's not a bacteria, and these two can coexist with one another. So for SIBO in particular, conditions that predispose to it are decreased gastric acid secretion, so in patients post-vagotomy or with chronic PPI use. In those with any type of small intestinal dysmotility, the stasis of the food can cause bacterial overgrowth. Iatrogenic or anatomic abnormalities, so any type of diverticulum that can have stagnant food in it. Surgically, if a patient has any type of blind loop, Billroth 2 anatomy, for the bariatric surgeons in the group, Roux-en-Y anastomoses can predispose to it. And then in some cases, disturbances in gut immune function. Patients will typically have nonspecific IBS-like symptoms, so abdominal pain, bloating, distension, diarrhea, or constipation. And then in severe cases, there'll be nutritional deficiencies, weight loss, and anemia. And since these symptoms are so vague, you really do need diagnostic testing to confirm, and you don't want to just treat empirically with antibiotics. So the mainstays of treatment are the breath test. So glucose breath test would look at the presence of intestinal overgrowth, predominantly in the duodenum since it is rapidly absorbed, whereas the lactulose breath test can test for intestinal overgrowth anywhere in the GI tract since it makes it all the way to the colon. Historically, cultures of the small bowel aspirate from the duodenum or the jejunum was performed, but it's rarely done, it's expensive, it's invasive, and results aren't always reproducible. So for the breath test, injection of either lactulose or glucose, and you'll look for a rise in the either hydrogen over 20 parts per million for SIBO or methane over 10 parts per minute over 90 minutes for intestinal methanogen overgrowth. And then depending on the report, you'll get a graph similar to this, and usually you'll see both lines on there, and it'll show you if there's that increase. And then mainstay of treatment, if it's the hydrogen predominant SIBO, it's rifaximin for 14 days. And if it's methane predominant, then you want to add neomycin to that. And then obviously correct any associated vitamin or mineral deficiencies. So in summary, non-invasive testing is generally the preferred modality to test for both. And then to check for active infection specifically, I've listed the diagnostic modalities that would be recommended, and then treatment once diagnosis is confirmed. That's it.